Thank you for this invitation to contribute to this very interesting panel. And to all of you all over the world, good morning, good afternoon, and here in Australia, good evening. I will first share my presentation. Okay, thank you. So I will just briefly give you a short flavor of the type of research we've done on COVID since the epidemic started. Australia has been relatively spared early on in the epidemic, and we've closed our borders to China at the very beginning of February, and we didn't have many cases developing. However, in early March, it started increasing. Mid-March, it started becoming more concerning, and very quickly, by the end of March, we went into lockdown. And so from mid-March onwards, we started really thinking about the type of research we needed to conduct to address major issues in the aging population and the population at large. And one key question that arose is, how will the epidemic, all aspects of the epidemic, have an impact on mental health? And so we started thinking of developing a longitudinal study that would span the next few months to answer this question, and while considering both the risk domains as well as predictive domains that might contribute to mental health. And so we recruited about 1,200 participants from the population. They were randomly selected, so it's a representative of the whole population at large in Australia. And we designed the study so that there would be 7 assessment waves spread every 2 weeks from mid-March until June, and then further waves to be planned after that. And we had a good representativeness of the population, as is demonstrated here on this figure, with individuals from about 18 years of age to about 90. They were predominantly from rural, city areas, but rural areas were also represented, and they came from all states, and there were an equal number of males and females. And at baseline, as we can see in the table on the top of this slide, if we use scales to assess whether people were likely to suffer from major depressive disorders or generalized anxiety. And in the total sample, there was a 3- to 4-fold increased rate in these disorders in our sample compared to what we would expect normally in the population. And this was particularly strong in people who had a prior diagnosis of major depression or anxiety. And below, we can see the trajectory at the bottom of the slide, the trajectory of depression symptoms and anxiety symptoms. And we can see that there were groups of people who followed different trajectories. And so while many were not concerning, there were about 10% of our sample who either remained very high or increased the symptomatology to quite concerning levels. And we also investigated what were the predictors of these levels and trajectories. And what we found is that direct exposure to the virus, being infected, having family members being infected, did not lead to greater symptomatology, reduced well-being, or poor trajectories, surprisingly perhaps. But what really had a major impact is the financial distress due to COVID and the work social impairment due to COVID as well. They all had a strong effect on these outcomes of depression, anxiety, well-being, and their trajectories. And what is particularly interesting is that younger age was a risk. So older people were relatively spared, which might surprise some. But of course, it's only part of the story, because loneliness and isolation, which affects typically more older populations, existing neurological conditions, and existing mental health problems were strong predictors of these effects. But also an important point to raise is that although we had a peak in COVID infections in March, April, it quickly faded, and these data are until about the end of June, so it's about here on the slide. And after that, we had a second wave. And so we don't know yet how the second wave has impacted mental health in the population and in older individuals, but we suspect that it's likely to be substantial. What is, and here I just want to present some of the figures of the number of participants who have been impacted in different age groups. So these are the number of cases across different age ranges, and we can see that overall there are somewhat fewer older people affected, although they represent a slightly smaller proportion of the population. But if we look at death, they much more overrepresented. And what is critical to consider is that these impacts have been particularly important in residential aged care, where a large proportion of those who died in residential aged care, whereas in home care there were not only many fewer cases, but also fewer people who passed away. And we've recently had the Royal Commission into Aged Care release a special report on aged care and COVID-19. And their conclusion was that the level of depression and anxiety, confusion, loneliness, and suicide risk among aged care residents have increased since March, which is consistent with what we found in our study. And also, they concluded that the measures implemented by the Australian government were insufficient to ensure preparedness of the aged care sector. And they proposed a number of recommendations and to address the concerns linked to the prevalence of the cases in residential aged care, because we often talk about the impact in terms of risk and death, but as we've seen in our study, loneliness and isolation was a strong predictor of mental health, and we also have to consider what happens when older people are just locked into aged care centres, can't see their families. And one of the recommendations was to allow continued visit to people living in residential aged care by their families and friends, as well as increased funding to allied health care services, including mental health, and establish a national aged care plan for COVID-19. So what lessons can be learned from the impact of the pandemic on older people? No doubt many and other speakers will cover several that I'm not thinking about, but we need to be proactive in thinking about the impact and in balancing risk and benefits of isolating older people. And what are some of the areas for future research? How can we maintain social connections? What do older people want? how can normal healthcare provisions be best maintained are some of the thoughts I came up with. So back to you, Sudesh.
Thank you very much, Nick. Very exciting, very interesting presentation. I've observed a few notes that I would want to further, clarify and get some clarity around some interesting observations that you have made. But we'll hold that for the final Q&A session.